Great, welcome everybody, and this is Boris Lushniak. I'm chairing today's meeting of the Commission on Public Health. We are in a brand new location, and I'd like to introduce Jennifer from Prince George's County, who wants to welcome us to this brand new location. So Jennifer, thank you so much for hosting us.
Hi, welcome everyone online. Welcome to everyone who's here. We just want to say that we're so happy to host you anytime. We are a Child Resource Connect. We operate lots of programs in Prince George's County. Our most exciting program relevant to all of you is Family Connects, a nurse home visiting program where we're serving 700 new moms every year and hoping that that's going to go statewide. There's actually a bill. So just want to put that in your mind. But please, anytime you need our space, we're so happy to have you. If somehow when you're all here, parking is full, you can park around the back. You have to drive around the long way, but there's a walkway that just comes around. And restrooms are on the other side of this wall. There are keys on the bulletin board right where you came in for you to be able to get in there. And I put out some coffee for the Keurig. Please help yourself. And welcome again. Thank you so much.
Well, thank you so much again on behalf of the commission for you hosting us here. I think this is going to be our home for the next few months. So thank you again. And also, we are always, even though we're public health people, always interested in snacks. And so thank you for your generosity in terms of introducing those into our life.
And our space was just painted, so it's going to get lovelier as we get stuff on the wall.
Right. Well, thank you so much, Jennifer. And I assume we're always dealing with brand new technology issues. So those of you who are online, and at this point we have 30 people online, please let us know through chat or through other mechanisms as to whether we have any issues with our audio visual. I'd like to welcome everybody here to our commission meeting. It is now 2:11 after that hour. Today is January 2025. My name is Boris Lushniak. As I mentioned, I'm serving as the presiding chair. I'm joined by my co-chair, Dr. Oluwatosin Oluteu, next to me to my right, and Dr. Meenakshi Brewster, who's on the virtual world along with many of you. Just to remind you all that the Maryland Commission on Public Health was established in 2023 to study and make recommendations to improve Maryland's public health system. This is a 16-member body comprised of local health officers, academic partners, thought leaders, and legislators. The Maryland Department of Health is represented by the Deputy Secretary for Public Health Services, the Deputy Secretary for Behavioral Health, and the Director of the Office of Minority Health and Health Disparities. Many additional leaders and professionals are contributing to the Commission's 5 work groups. These work groups will explore 5 key subjects relevant to the mission. They include funding, governance and organizational capabilities, workforce, data and information technology, and communications and public engagement. The Commission's goal is to ensure the public health system is designed to help all Marylanders achieve their best health and a lifetime of wellness. Meetings are held monthly and streamed online, and for more information, please visit our website, which I think we're now reorganizing, right? Do we have a brand new website address? Please share that with the group.
It is health.maryland.gov/COPH.
Okay, health.maryland.gov/COPH, Commission on Public Health. We thank St. Mary's County for having hosted our website all these months. Everything has been transitioned, I think, successfully to the new site, so welcome to the new site. This is a public meeting, and we have followed the requirements of posting a notification of this meeting. The meeting is being video recorded. By your continued participation, especially those of you online in this meeting, you consent to the video recording. We ask members of the public who may be attending to mute their microphones during this session. This meeting does not, I'll repeat, does not include a period for public comments, and we will not be monitoring the chat function during the meeting. We, however, do encourage public comments to be sent via email, and I think the email address still remains the same as md.coph@maryland.gov. That number again, maryland.coph maryland.gov for public comments by email. We also ask members of the commission to mute your microphones when not speaking. Please use the raise hand function to indicate that you wish to speak, and you will be recognized. We'll be monitoring the hand raises that go on during today's session. Individuals who serve on the commission are subject to Maryland public ethics laws. All have confirmed their agreement to this in their applications and listed any conflicts of interest. There are attendance requirements for individuals appointed by the governor, which are outlined in State Government Article Section 8-501 of the Annotated Code of Maryland. And so that we do expect almost all of our meetings to be fully attended. This does not apply to the ex officios who are representing some of the government organizations. In order to assure that we are well represented here, I will now ask Shane to conduct a roll call of the commissioners. Shane, please do so.
When I call your name, please respond with here or present. Delegate Bagnall. Camille Blake Fall. Christopher Brandt. Mina Brewster.
Here.
Jean Drummond. Senator Lamb. Dr. Levy.
Here.
Alyssa Lord. Boris Lishniak.
Here.
Nilesh Kalyanaraman.
Here.
Tosin Olateju.
Here.
Fran Phillips.
Here.
Laura Rossman.
Here.
Nicole Rochester.
Here.
Michelle Spencer.
Here.
Alan Twiggs.
Here.
We have a quorum.
And I think we saw Chris Brandt.
Yeah.
Has it. Okay. Okay. Thank you, Chris. We have a quorum for today's session, so all voting that will take place will be under the ramifications of that quorum. The agenda for today's meeting has also been posted and distributed to the commissioners and also is available online. Are there any comments from the commissioners regarding today's agenda? If there are not, then I ask for a motion to approve today's agenda.
So moved.
Fran Phillips, second.
Olateju.
Tosin as a second. Everyone who accepts today's agenda, please say aye or raise your hands online.
Aye.
Anyone against today's agenda? Any abstentions? We have accepted the agenda as stated. We also have minutes from the previous meeting, which took place on December 5th, 2024. They were posted and distributed. Any comments on the minutes from commissioners? There being none, I ask for a motion to approve the minutes from December 5th.
I so move.
Who was that?
Michelle Spencer.
Thank you, Michelle. Anyone as second? Who was that? I'm sorry.
Mina Brewster.
Mina seconded. Okay. Let's take a vote. Do we accept the previous minutes from December 5th? Everyone who agrees, please say aye.
Aye.
Or raise your hands online. Anyone against accepting the minutes? Any abstentions? Great. Thank you. We're going to move shortly to our guest presentation. Very excited for our guest presentation. I do, however, want to begin with an opening statement to today's meeting. First and foremost, this is our first meeting of the new year, 2025. And so I do, in a belated fashion, some believe in this tradition that once it's after the 15th of the month, you can no longer say Happy New Year. I am not a believer in that. I actually celebrate the New Year well into June. That being said, I wish you all the happiest of New Year's for 2025 and the best to you, your families, your loved ones, and most importantly to our mission. which will culminate this year with a final report. So we have a big year ahead of us in 2025. I also want to acknowledge the staff that is present here today. We have Jonathan, we have Sarah, we have Shane, and anyone else here in the room. Thank you all for your important role on this commission, and really running things behind, not only behind the scenes, but also in the forefront for making us much more efficient. I also want to remind you that we're probably into the next few months of not having some of our legislators on this call or in person here, because we are now, to remind you, in the state of Maryland in a legislative session. So there's a lot going on out there. We appreciate our friends from the Maryland Department of Health and other local health departments as well, who may be at times called to Annapolis to either testify or be at hearings. We understand that these next few months are filled with many, many activities. But thank you again for your presence and your activism. The last thing I want to bring to sort of to the forefront, and I don't want to make a big issue out of this, but I do want everybody to be careful, is the sense that this commission thus far has issued 2 reports. The first report was an initial report called the first interim, which in essence told of a few weeks of progress and where we were heading. The second interim report, which was issued in December, talked about our activities and our observations in that point in time for our year's worth of activities. We have not yet issued a final report. And the reason I'm emphasizing that is that as we enter legislative session, I want to make everyone quite apparent that things that are said at this legislative session in the form of hearings, in terms of observations, whether it's coming from elected officials or others, they certainly are privy to this idea that these are open sessions. Everyone can see videos and minutes of what we are discussing. But most importantly, and this is something I really want to sort of hone in on, is we have not come up with recommendations. So anything that is out there are strictly observations that are taking place as we're discussing things. And I want us to have vibrant and active discussions. If that means at times bringing things to the attention, saying, well, we hear or we're observing that something's not working, that's fine. But if it's now being misinterpreted as if the commission has spoken strictly on a perspective of what the recommendation is going to be, please, for the commissioners in particular, be very careful, but also for anyone out there in the world who's using our information, that they be deliberate in the use, right, of it, and basically acknowledge that these are not the final findings of this commission and the recommendations thereof. So thank you for allowing me to sort of talk about this legislative process that's going to be taking place. People are paying attention to what we're saying. That's a great thing. Yay us, right? Yay us. But what we don't want to do is this being misinterpreted as if we are now done with our work, because a lot of our work is ahead of us. Any comments or questions on this? Yes, Fran.
Yes, thank you. Thank you, Boris. A couple of things. I think we all understand the point of your comments, this being a legislative session. However, here, 2 things.
Yeah.
Here's maybe a request and a however. The however is that the commission has gone on record with a recommendation with regard to the Population Health Trust, which was an element in an approved HSCRC proposal having to do with the AHEAD model. There's going to be legislative action with regard to that proposal, and so we have gone on record as favoring supporting the Population Health Trust for the reasons that we specified in our letter. So, so there's that. We might even be invited to make some oral or other comments to a legislative committee, and so for that reason, I want to suggest that the commission have a protocol for legislative updates, for communication, which may be on a short fuse with regard to legislative action. Mm-hmm. It may be around that issue, or it may be around other issues. But recognizing that we may be called on as individuals, we're not here as individuals. We have an individual life, but we have a life as commissioners.
Right.
And so I want to ask if there are thoughts from our co-chairs about how to manage what may be some short time frame requests for communication.
Yeah, I think point well taken. Anywhere where we have spoken as a commission and in essence put up something for a vote, that is a decision by the commission. So, as for your first example, that is something that we are supporting. In terms of protocol, I think this is, something that we can certainly take to our executive session of the commissioners. We meet on a weekly basis. And I take that as something is an action item, right? For us to be able to say is in this, this is our first real legislative session where we spent a vibrant year. And so I think two things, one of which is we are noticed more by others than we have before because of the excellent work going on. We also have more information and more data and perhaps more in terms of opinions. I think there's two components to this, and I will table this to our executive session next week. Shane, if we can add, or Sarah, into that to agenda item, which is come up and propose a protocol on this in short time, because we are in the midst of a legislative session. In the midst of this, I will also request all commissioners that if you are asked to be at any hearings or have been, or even volunteering to be at any hearings, just give us a heads up as to whether you're there have you been asked as a commissioner, have you been asked as a private citizen, how that's going to work, just so we can sort of keep and sort of tabs on who's out there speaking, but also where we can, in essence, spend some time both getting debriefed afterwards, as well as perhaps briefing beforehand of saying, okay, so what's the thought on this? I want us to be active participants in this legislative session.
So in that,
Yeah.
thank you. And so on that point, maybe we want to have some opportunity for staff to be monitoring those bills as the relevant bills as they come up for hearings in committee, and rather than wait to be asked, to indicate to committee staff our willingness. So kind of be mutually engaged,
Right.
both not just waiting to be invited, but to suggest that we might have some expertise to shed on that.
Great.
Fran, I think you make a good point. This might be one area, where we can utilize our interns,
Well,
just
however,
to,
yeah.
because keeping in
Yeah.
mind of the, just how, tight how short we are in terms of, the staffing and, thank you.
Yes.
Yeah, I mean, I guess, a couple of things. One, I think if individuals got asked to testify, I think it's one thing to say, here's what the commission has said, and the other thing, it's like, any commissioner should be able to testify and do whatever they want.
Mm-hmm.
I expect, like, especially regarding the Population Health Trust, there's probably some divergent views in the room around how the governance of that should be structured. And like, I think I think it'd be great to have that conversation and like, talk about the pros and cons of that. I think it'd be a valuable use of the expertise on the commission just to have the conversation about it. I don't know that that's going to fit in the agenda, but I would say that. But I definitely wouldn't want to try to muzzle anyone.
Right. And that's not the intent, right? The intent is where, what I don't want to do is to make sure we aren't misrepresenting ourselves as we're testifying, right?
Saying this is me as an individual,
Right.
not speaking on
Right. But at the same time, I take Fran's, recommendation to heart, which is not only be reactive, but where we can, let's be proactive on some of these issues. And whether that's done as an individual basis or as members of our commission, we can determine what our role on this is. One approach
But I
is,
think what Chris is saying
Yeah.
is beyond that. It's like, we don't really we have this generic, we think the Population Health Trust was good and
Yeah.
resources there, good. But the real nitty gritty that the legislature is going to grapple with and decide is, what is the governance structure? Who's on that board and how does it operate? What kind of legal entity will it be? What kind of allocation? Just lots of predicates to this organization that we as a commission haven't talked about.
Yeah.
So, and I think that would add much more value if we have to a hearing, to some testimony, if we have some recommendations in that regard.
So the question,
Rather
of
than
course, is-
motherhood and apple pie, yeah, we
Right.
love the trust, like, what should the trust actually look like, structure, and how should it function?
so the question really is, I think at this point, first of all, do we have a timeline of when those hearings would be taking place?
They're now. They can change, get called tomorrow.
Mhm.
I mean, it's up to the committee chair, so, yeah, I don't know where they're, I think it's an administration bill. I mean, it's got legs.
Okay, I'm thinking at least, we have to sort of follow the agenda as we have said today. As we finish up our agenda, the question is under the category of other, can we bring this up and
Sure,
at least
yeah.
have a discussion under that?
I think it'd be an interesting conversation and even just to hear the position
Right.
of some really.
Because my hope was going to be that you would tell me that it's not until next month, in which case we can actually add this as a full agenda item to our February meeting. Our meetings are already, in essence, is if this is something that commissioners want to be able to discuss, then let's do so. Let's begin under right before closure of other. And I don't want to rush our discussion today, but begin formulating your sort of frame of mind and how you want the commission to be handling this.
If we could get to a consensus where there was messaging on this,
Yeah.
that would be probably pretty powerful, but I don't know that we'll get there.
Well, those of you who are activists in this, begin formulating what you would like to say, because you will have a voice. Okay, thank you for that. Any other additions or anything else?
I would just point out two things. I would point out that we have a funding work group, who hopefully is looking at the funding sources of this Public Population Health Trust. So they may be also a resource for it to look to. And then the local health departments through MACHO are also looking at this legislation looking at the way it's rolled out closely
Mm-hmm.
and trying to advise on that also from a separate entity.
Okay. Great. Thank you, Matt. Okay, let's move on with the agenda, and those points, we'll table them at this point and bring them back. In terms of sort of the protocol, we'll take that to executive session and come back something with, I think that's very good. Let's bring up now our guest presenter, and I'll have Tosin introduce Kathy Oak.
Thank you, Mr. Chair. All righty, want to welcome Kathy Oak. Kathy Oak is a law school professor at the University of Maryland, Carey School of Law, and serves as the executive director of the Legal Resource Center for Public Health Policy. Additionally, she is the director of the Eastern Region for the Network of Public Health Law. Kathy teaches a seminar on public health and the law and supervises the Public Health Law Clinic, which provides law students with the opportunity to practice public health law through the network and the LRC. Her work encompasses a wide range of public health law and policy issues, including public health authority, access to reproductive health care, maternal health, housing, food safety, and security, including injury prevention, regulation of tobacco, cannabis, and alcohol. Kathy places a strong emphasis on health equity in all of her efforts. Please join us in welcoming Kathy Oak. Thank you so much. Please.
Hi, everyone, and thanks for asking me to join. Shane, I assume you're going to progress the slides. Is that the way this goes? Yeah.
Yeah.
I see the next one coming up. Terrific. Thanks for inviting me. I have to tell you, people might not believe this because they know Fran and I are pretty cozy with each other, but I did not set up that conversation. But I'm going to touch on some of the things that and pick up on that thread about your engagement with the legislature in a more broad way, not just about the Population Health Fund. I don't necessarily have comments on that, but certainly at the end of the day, I think what you're going to find is my encouragement of each of you as individuals, this entity and other entities that you're engaged with, to be involved in the legislative process. And I'll offer out my support and assistance to you in doing so. So yeah, I actually have kind of two slide decks and one that represent the two hats that I wear. I mean, there's also my professor hat, but a couple of hats. Oh, also, let me just pause and say I'm aging myself here, but when I looked on the screen at first and saw all the names, at least of the folks who are online and folks who I know are in the room, I felt like Miss Sally on Romper Room. Oh, I see Michelle, I see Nilesh, I see Mara, and it really made my day. I think think it's never too late to say Happy New Year. So I agree, Boris, that it's still okay to say Happy New Year. And then we get to say it again, those of us who work in a fiscal year in July, all throughout the month of July, you can say that as well. So I will always take those greetings. So 2 slide decks. One really is kind of this national landscape. What I'd like to do is situate for you what's been going on around the country with respect to what I say public health authority. And by that, I really mean who has decision making to, for example, declare public emergencies, who has decision making power on how to use public health resources, the shifts of that from executive to legislative, from local to state, et cetera. There's just been more activity in that space nationally in the last 5 years than we had seen in the, prior probably 5 decades. So I want to give you a lay of the land, the landscape nationally. And then I'm going to walk you through what that really looked like in the Maryland legislature and where we are, and maybe again offer out some kind of parting thoughts for you as individuals who have voice in public health space, as well as the organization itself. I do serve on the government and organizational capacity or capabilities work group, and I do know of the work from the other group. And then later today, you're going to hear from a panel I helped put together that's going to talk specifically about 3 of the other work group stuff. So funding, workforce development, and workforce and data. So I'm going to talk about kind of that government and organizational capabilities stuff. So next slide, Shane. Just situating things. This is a report that the Network for Public Health Law with some partners put out, from which I'm drawing this information. So actually many lawyers across many organizations put this together. Go ahead, Shane. So the big question, what I call the good, bad, ugly. What did happen over the course of the last 5 years or 4 years of legislative sessions as a result of COVID in the public health authority space? So you're going to see the good. This got overshadowed by the bad, but the overwhelming majority of states supported and maybe even buttressed the public health decision making to be remaining with public health officials, right? So allowing the Secretary of Health, allowing local public health to maintain their decision-making authority, and actually supplementing resources to those offices. So despite all the bad news, there was actually a lot of good. The bad news is some legislatures around the country, kind of adopted an anti-regulatory framework, and both through legislative action and through judicial action. So, masking orders or school closures were, getting challenged in court and the like. And so both through the legislative body and the judiciary, we saw a lot of curbing of public health authority. So not necessarily removing the power from the local, public health agency, but saying mask mandates aren't allowed because there's no justification for them or what have you. So really that anti-regulatory state. But there really was ugly, right? And the outcome, the kind of the big picture of the ugly is that those states that turn to an anti-regulatory state, removing power from local public health, removing power from state public health, giving the legislature all of the public health power, kind of unchecked by the governor or vice versa, that remains intact today. That wasn't just then to deal with how we respond to COVID, whether employees should have to be vaccinated, whether schools can open, et cetera. And so we're really going to deal with, in those states, they're going to deal with the complications of the removal of public health authority from folks like you all who actually have the experience, education, to engage in good decision-making in public health. Next slide. So what does that look like kind of specifically? What were legislatures doing? So this is the bad, right? In some state legislatures around the country, they preempted a lot of local government action, right? And I know we have this quasi, state local setup in Maryland, but we do actually have, broadly speaking, outside of just the local public health space, we do have broad power in our counties throughout the state. I mean, there are 6 counties that don't have home rule power, but all of the others have really plenary power in the public health space. And this state has not preempted that, generally speaking. But in other states, either very broadly or, piecemeal, they have preempted locals from taking action in the public health space. They've broadened exemptions. For example, allowing for the philosophical exemption from childhood vaccinations for school entry or daycare entry. Of course, the kind of personal belief really drives the Mack truck through the word mandatory vaccination, because if it's easier to not get the vaccination than it is to do it, a lot of people will pick that even if they don't have an objection. And then also kind of the notion that religious beliefs or kind of religious organization should be outside the scope of public health mandates or restrictions really played a role in many states and in some courts. And then finally, the shifting of authority. What we really saw throughout the country that looks to be, the expectations are that it will continue and that there are negative consequences to it is taking power away from the public health agencies, like I said, a state department of health or local departments of health, creating a lot of these unwieldy situations where it is the legislature that has the power now to declare an emergency, or the governor perhaps can declare an emergency for 30 days, but after that it can only be renewed on agreement with the legislature, which may not be in session, which, as you know, is not comprised of people who understand what an emergency is. They certainly don't work quickly and the like. And so it's really created an unwieldy situation for declarations. Next slide. Courts, again, have been involved in this. Again, as I mentioned earlier, they're narrowing the interpretation of public health power where we thought, language in statutes was broad enough to give broad power. They are looking, allowing for individual rights, if you will, and philosophical and religious beliefs to really trump the public health powers and the emergency powers. And some have really, this is probably most devastating and academic. There's a lot of academic literature, a lot of scholarship on this and the, kind of longstanding impact. Courts really walking back on their historical kind of deference to public health, right? That there's expertise in science that supports the work that we do. And so courts should give kind of credence to that when a public health measure is being challenged. And we really saw a walking back of that. And again, in a pretty kind of devastating way. For those of us who are lawyers, we asked Jacobson versus Massachusetts, which is the Supreme Court that basically said there is this, public health power, and it was used to uphold a vaccine mandate back in the day. Is that still good law? That is law that really is the foundation of public health law throughout this country. Next slide. So what's the impact of all of this? I don't need to tell you that when we take the power away from public health officials and give it to either executive agencies or executives, meaning governors or the like, that don't have the education experience to understand epidemiology, to see where trends are going, we don't get decisions that are made based on science. They're made based on politics and what the whim of the community might be at the moment. It's hard to be a public health official and make an unpopular decision, but I know lots of folks on the screen that are willing to do that. Other types of elected officials aren't necessarily in that same space. Obviously, it hampers the ability to respond, particularly to emergencies. If every time you want a declaration of emergency, you have to run to, the legislature, have them convene in special session to determine whether you can declare an emergency and or how long it might last. And then, the final bullet point might be, a little more obvious today than when I've given this talk in the past, but elevating politics over public health expertise. Next slide. That's not going to end well for any of us. So just so you know, tracking the changes, we are always the network and the other organizations we work with are continuing in this work of seeing what changes. I mean, the volume of proposed changes has gone down significantly, and we'll see that also when I show you what has happened in Maryland in the last 4 or 5 years. But we're still tracking it. If you want, if you have anything, I'm actually going to talk about whether you want, kind of insight on tracking legislation in Maryland this this year, but keeping an eye out. This is kind of more generally keeping an eye out for legislation that doesn't look so obvious that it's taking away the power, but if it's preempting any, local action or kind of reserving in the legislature action. I keep a track of that in Maryland. So that's a more generic comment outside of Maryland. Next slide. If you want to be proactive, we do ask that people, stay in touch with us. But go ahead, next slide. One thing we did create was what's called Fighting for Public Health. And that was really looking at public health broadly, but I actually do know enough about my own state to say this applies here. And that is, we have lots of opportunities, right? We don't look at them as things we haven't been doing well, but like opportunities of spaces and places where we should be. So our Fighting for Public Health study found that public health officials, public health professionals, even organizations that are centered on public health are really not particularly, I'm not gonna say good at, but at the table as advocates as often as they should be. I know a lot of people shy away from it because it's politics or because it doesn't feel like the place and space where you're comfortable. But we do know that in a vacuum of public health voices at the table, legislators can't and won't make the right decisions for us. So, we want to see and support folks in kind of helping them determine how to be better public health advocates. And then also bringing friends to the table. Again, I think, we work collaboratively in public health in this state with lots of, community-based organizations, the university engagement, right? University engagement with public health, but really cultivating friends outside that natural scope. What organizations, entities, businesses, really do benefit from the public health measures that we put into place and enforce, and should be, kind of partners with us, helping us to support, legislation or policy change that we are promoting, because doing it alone isn't really going to work. And this middle prong here, the number 3 that you see is, exciting models exist. And I actually, I've talked about this a little bit with Fran and others, that we have MACHO, which, everyone knows I'm a big fan of MACHO. I try to provide as much support as I can. But states that have really strong and well-funded, we call them SACHOs, state associations of county health officials, they really can have more voice, and they can do some of that work in prong 1 and 2 to help support the public health community. But MACHO doesn't actually have the resources right now to do that. So whether and how to build up those resources, I think, is an open question here. I'm going to jump down to the last prong, and that's about funding. We're going to have the workforce and the funding. We're going to have 2 folks talking with us later about some innovations in this space. But no doubt we in Maryland suffer, as we do nationally, from access to a trained, educated workforce who will stay in the positions that they're in, as well as unlocking funding to do the work. Next slide. So actually, we can go ahead through the next slide as well. Next slide. Sorry, I forgot how many slides I had. So I really want to stop there with my national stuff. Those last 2 slides were just what I have been saying, about those prongs. But if you want any more information about the national space, just let me know. We have a ton more resources. That was about a third of a presentation that I typically do when I'm asked to do presentations on this issue outside of Maryland. But I wanted to be able to spend some of my time here on kind of what's been happening in Maryland with respect to Public Health Authority and the legislature. So go ahead to the next slide. This is a bit of self-promotion, but if you don't already know, the Legal Resource Center for Public Health Policy hosts a bi-weekly conference call. It's on Tuesdays at 11:30. We just had one this week. That was our launching one. So the next will be I think Tuesday, the 4th, here, where we talk about public health legislation in a bunch of different subject matter areas. We clearly do tobacco and cannabis. That's what we're funded to do by the Maryland Department of Health. But there are other tabs on our trackers. We have alcohol on the tracker. We have school health. We have motor vehicle. We have child and maternal health and food policy. So we talk about all, kind of bills pending in all of those. Oh, and gambling, I should have said. I'm sorry. We're also funded to do gambling work. And so we talk through bills that we think might be of interest. Most of the people who are on our calls are from the state or local health departments. Anyone is welcome. We do have some advocates from different organizations in those spaces who join us as well. There is a chart, and I don't know if you all can, that link will work with what Shane sent out to you. If not, I'll make sure I get the link to you, but it is to a tracker that is 24/7 live. It is a Google Doc that you can't edit, so don't worry, you can't mess it up, but you can look at it. And our students are updating it. My public health law students are updating it kind of regularly with new legislation that comes in, as well as where is, when are hearings being scheduled, has a vote been had, et cetera. So you can always check the status of any piece of legislation that we're tracking through that chart. So I want to say we did used to have a tab for public health authority because in 21 and 22 there were a lot of bills I'm about to talk about, but we took it off. There really weren't that many bills moving forward, and so we didn't have that as a tracker. But let's talk at the end about whether and how I might support this commission in keeping an eye on legislation that's of interest. Next slide. So public health authority legislation in Maryland, 21 to 22 is a totally different animal than before, when there was hardly any legislation ever looking at the construct of our system between the executive branch and the legislative branch, between the states and between the locals. And so there really was a dearth of legislation prior to that. But obviously, during the height of COVID, we did see legislation introduced. I just want to situate it that at this time for 21 and 22, Republican Larry Hogan was the governor, so there was chasm or conflict between the governor and the legislature on lots of issues. I will say we also did some good work in making sure the executive and the legislature were working collaboratively for the protection of the public in COVID. But there were certainly conservative members in the legislature that were seeking to restrain public health powers, actually of the governor, even of their own party, but as well as for state and local. There is some outlier legislation that also was designed to protect public health officers and the like. And so I'm going to flip through a couple of slides to give you some specifics there. So next slide. This is, these are some bills that were proposed during 21 and 22. You can see they were kind of reintroduced from 21 and 22 that were directly interfering with the governor's authority to issue a declaration of emergency during a public health crisis. And the declaration of emergency triggers the governor's access to resources, your local and state public health access to resources. It allows kind of the suspension of some laws that might interfere with the ability to protect the public health. So the declaration isn't just a declaration; it has significant legal impact that we really needed during COVID. And so not allowing the governor to issue a declaration of emergency or sustain one for a period of time that we couldn't have predicted in March of 20 we were going to need to do would be very harmful to public health, because each of these bills, as you can see, would have said the governor can declare an emergency under the existing law for declaration of emergency, but if it's going to go past a certain period of time, 14 days, which obviously sounds absurd, or 30 days. So they would have required them for the legislature to be involved in whether there would be a declaration of emergency for the state and what that would even look like. So you can see both of these would have severely hampered the state executive's ability to declare emergency, which then perhaps would have, if these passed, meant locals were declaring states of emergency, but not having the same impact that a counties could have been declaring declarations of emergency, but it wouldn't have the same impact as the state declaration. Next slide. We also saw during this time direct attacks on mask requirements. I don't need to tell Dr. K about this because he was hot and heavy in Anne Arundel County about mask requirements during COVID, but there were bills introduced to literally prohibit requirements, any requirements, regardless of whether it's state, local, et cetera, for people to wear masks in public, right? Whether it's on public transportation or in schools. There was one specifically, prohibiting masks from being required in schools at the state, by the state, saying locals should get to decide that. Interestingly, and the counter to it was there was a bill requiring the Secretary of Health to issue a mask mandate under certain conditions by the CDC. This, I think, was considered a pro-public health piece of legislation. It didn't pass. They're in red because they didn't pass. If you see a bill in green, which you'll see in a little bit, they passed. Because there was a concern that at that time, the governor and the secretary may not have been, kind of as public health oriented as some of the legislators had wanted them to be. That bill did fail, though. But just so you know, there were folks trying to preserve clearly the ability to issue a mask mandate. Next slide. So last, I think on this 2021 and 2022 is the attacks on vaccination. So there were bills put in 2022 to prohibit the requiring essentially of COVID vaccination, of any vaccinations beyond the existing school entry vaccination. So this was kind of preemptive to say schools, daycares can't mandate that a child be vaccinated for COVID before coming to school. And then similarly, you see the bill that related to even more broadly, but that schools, employers, universities could not even ask about vaccination status, like for employees, for students coming back to campus or the like, not even allowed to ask about vaccination status, and certainly not allowed to discriminate, meaning you can't, say an employee can't be in a certain workplace if they are not vaccinated. There was an exception for healthcare facilities in there. So that's what we were seeing. Next slide. That's what we were seeing during the height of COVID in the Maryland General Assembly. I forgot I added this one more. So this bill would have, and this is an example of what we did see from courts around the country, but really saying that if the governor declares an emergency, religious entities, so how that's defined is anybody's guess, right? But let's just say a church, a temple, what have you, would be allowed to operate in the same ways that essential services were allowed to operate. That, churches and schools, churches and temples would not be put in the category of, a bike repair shop or a sandwich shop or the like, but they would be put in the category of essential services, kind of amping up the ability of churches to operate. Again, the kind of the breadth and scope of where religious rights are hampering public health efforts around the country is real. This Supreme Court is likely to make that even worse, and this was an effort in Maryland. So next slide. Sorry, I forgot I had thrown that one in for good measure. But there were bills introduced during this period of time that were specifically about public health officials, not the authority that's shifting who's allowed to make decisions about what, but specifically designed to protect public health officials and their staff. One passed and one didn't. And the didn't has been a source of contention, I think a thorn in the side for lots of us here. What did pass, and I don't want to go through the whole thing, but in 2022, there was a bill that was considered that really created additional I don't know if I want to call them protections, but additional process for local public health officials being removed from their position. And this does relate back to, I think, lots of controversy associated with the removal of the health officer in Harford County during this time. And so this really creates some process, some notification of the basis for the termination and appeal process. So, why this kind of mattered at the time and matters continue. I probably don't need to tell folks, but if public health officials are legitimately afraid of losing their job for making politically less savory decisions, they might not make them. And like I said earlier, I feel confident that the group of public health officials we have in Maryland makes decisions based on science. Yes, takes into consideration whether the community will accept, and is there a measure that's better in one community than another. Garrett County is not the same as Baltimore County, and so considering community engagement, how a community will receive that order or that restriction or that requirement does get taken into consideration by our local public health folks. But if they're really having to worry too much about politics, it's really tough to do the job. So this is like part of this bill passed, right? It was a much more extensive bill when it started. This is the part that passed, but certainly a positive. But what didn't pass and what has continued to not pass is a law that would add public health officials and their staff to an existing statute, essentially. I mean, there have been different approaches to doing this that protects certain public officials from threats of violence. And so it kind of amps up. Obviously, there's an existing statute that protects anyone from threats of violence in the sense that you can, bring a cause of action. You can bring seek a protective order, or you can, call the police if someone's harassing you. But we know that having a specific statute that addresses and protects public health workers is incredibly important. Throughout the country, we saw a difference in states that had that kind of protection and that didn't, with respect to whether and how police were willing to respond in those situations, and even the public messaging about, hey, leave the public health team alone. They really are trying to do what's in your best interest, even if you disagree with that, but don't make these threats. So we were unsuccessful in getting that legislation passed, again, trying in lots of different ways. Next slide. So that was really the 21 and 22. We were then again under the Hogan administration. And so there was, I think, different kind of thoughts or perspectives about what the state would be doing in certain spaces. And the COVID, obviously COVID I just had it and it was wicked awful. So I'm never going to say it's over because it's not. But I think our daily kind of focus on COVID was kind of settling in by 23. It was the Governor Moore's first year in office. And so the kind of bulk of legislation, which I only gave you some, there were more of each of those kinds of bills that I talked about. All of that we saw in 21 and 22 kind of fell off of the screen. And we didn't really see that kind of attack. There was the Vaccination by Choice Act that was proposed in 23 that essentially was like one of the bills I talked about earlier, where you can't mandate someone for school or for employment be vaccinated or even have to share their vaccination status with you. But there really was in 23 a dearth of bills directly addressing public health authority. I do want to pull a couple of highlights out, though, that bills that did pass in this space that probably didn't get the biggest fanfare because they're kind of narrow in scope, but the Mental Health Workforce Development Fund was passed. Raise your hand if you're a local public health person who has more than enough resources in the mental health space, right? Nobody raised their hand. So the Commission on Behavioral Health Treatment and Access, super important. I'm working with the Legal Action Center this session on bills relating to access to behavioral health care in Maryland. So the creation of that commission should be celebrated as a win in the public health space. And then lastly, really took the Rural Health Collaborative Pilot, renamed it the Mid-Shore Health Improvement Coalition, and funded it. And so said, yes, we're still going to be looking in that space, and we're actually going to be funding those efforts. And again, I'll just put the caveat of there was not a bill in 23 that was to protect or add public health workers to that, public health officials being protected from threats. But interestingly, there were for election workers and first responders. And so we kept thinking we could get in with them, but it just didn't happen for us. Next slide. So I will say the 2024 legislation, so from last year, the governor's second session, I want to be positive and optimistic and hopeful, but we didn't see, a lot of work a lot of support in the progress on bills that would have been really supportive on the workforce side of things, right? Again, no threats bill, but there was a bill in that passed that was protecting against the public disclosure of personal information of elected officials and judges, none for public health. I happen to know some local public health officials that would have really preferred that their personal information, where they live, what their phone numbers are, et cetera, be subject to protection by law. And they sadly weren't included in this. The one that I just don't understand how it didn't pass is, recognizing a community health worker appreciation day. The fact that a bill that costs the state nothing, really, right? That would just say to the folks who, we know made a difference in COVID and make a difference every day in our communities, particularly in our communities that have, for which they suffer health inequities associated with, systemic and structural racism. Community health workers make all of the difference, and we couldn't even have a day to appreciate them. The Interstate Social Worker Compact, that's really designed to say, we know that not everyone has access to social workers in this state, and this would allow social workers from other states that have agreed to the compact. So there are some protections to make sure folks are getting good care, but the social workers from other states could operate in Maryland. For some of our rural communities that are adjacent to other states that might have more resource, would really benefit from this compact, and it did not pass. The bill is in again. And it's on the agenda next week for hearing. So fingers crossed. Similar bill for advanced practice RNs, right, to allow states that have agreed to the compact, those professionals to practice also in Maryland, and Maryland professionals to perhaps practice in other states. And then the last little highlight here that says to me, like, where is the legislature when it comes to supporting the public health workforce is, a bill that would have given local behavioral health administration or oversight of the services in their county. I actually don't know whether some locals might not want that, but I do know that many did want there to be that they have local control over the behavioral health services being provided in their communities, because they're right there, can have a better beat on what's going on. Next slide. What did pass? So I always like to have some positives in here so you can see that they're in green. And that is an extension of the Maryland Community Health Resources Commission with the broad mission to improve healthcare access through community health resources. So, don't know that necessarily helps local public health or the state, agency as such, but it certainly is looking at what better ways to leverage the community resources that we have to improve healthcare access throughout the community. And then because we do have the data and IT work group, I wanted to mention that a bill passed that requires modernization of our IT throughout the state. And so the Department of Information Technology is supposed to be improving. So data sharing, which I know is a huge issue, data analysis and assessment, like our ability to do all of that is constrained by the resources that we have through the state. And so the state did pass this Modernization Act, but there's a specific provision in there that indicates priorities for certain types of IT needs, and public health is specifically mentioned in there. So I'll take that as a win in the data IT space. Next slide. So these are just my takeaways, and I have lots of other opinions, but these are the ones that I think, I wanted to draw, and that is, to rein back in what Fran was saying at the outset, whether it's the commission. And I do think this commission has the opportunity to bring important issues of public health practice to the General Assembly. And with the final report, I know you will do that. I'm excited to be part of a work group that is going to be doing that. But individual members here too, in whatever capacity, as either just human beings or in your official capacities for whatever your jobs are, can and should they need that. The legislature doesn't really handle public health particularly well, and so they need the insight and expertise from folks. They tend to just be reactive, and public health can't afford to just be reactive. We have to be forward-looking. We have to anticipate, but the legislature doesn't function that way. And so however we can help the legislature see that just working on the shiny nickel for today is not giving us the best protection in the state against public health crises. And so again, I'm hoping that this commission's report captures lots of headlines and gets the attention of legislators. It'll of course come out after session, which is good because they can't do anything but read the 2,000 plus bills that they're looking at this session. But that's where I hope things go. Last slide is just my kind of contact information and open the floor for questions or whatever your process is. But I do just want to say, if there are bills that you know you want to track. And maybe Shane, maybe you and I can touch base about this or what have you. I can get them on my tracker and have a student who will every day go in and update the tracker. I would just put a tab that said Public Health Authority or something on our tracker, or I can create a separate tracker that would be for you all, and have a student every day update so you'd know when hearings are being held, or when bills are being voted on, what the outcomes are. So we can talk about whether and how I can support you in that effort. There you go. That's what I got.
Thank you, Kathy. That was really quite helpful, and several things. Sort of your closure of talking about how, you know, the report that we issue really should be the headlines. You know, you said could be the headlines. I think we should put it on our shoulders to that it should be the headlines, because as you know, as you stated so well, that a lot of what we're talking about needs, you know, to be discussed at the General Assembly level. We want that to have traction. Kathy will also be back and running another session later today at near the closure of the meeting with some of our other guests. But does anybody from the commissioners have any comments or questions for Kathy? We just have a few minutes before we take our break here, but anybody have anything? Chris, you have something?
Yeah, a couple questions. And these may or may not be within your purview. Thank you for coming to speak with us. One question I learned recently, among the things we've talked about a little bit in here, is, you know, sort of the broader sort of public health and population health as more than just what's happening explicitly in the local health departments or the state health department. But Medicaid in particular is a big share of where we need, you know, sort of better community health, and some of the biggest players in Medicaid are the Medicaid MCOs. I learned recently that the procurement process for the Medicaid MCOs in Maryland is seemingly pretty broken. Okay. The incumbents never get really recompeted at all.
Mm-hmm.
And so, you know, there's a certain amount of just like fear, like, I guess if they try to recompete or impose more requirements on the Medicaid MCOs, the MCOs then just sue the state, and the state just doesn't want to deal with it. So they just kind of roll over.
Mm-hmm.
And I'm wondering if I heard that from a reputable source, but like I'm very curious if you have sort of an expert opinion on whether that's true relative to what's happening in other states, and whether we could at some point in our recommendations address that in one way or another.
I hate to do this to you, Michelle, but you laughed, and so I don't know if you have some insight, or if you're just saying yes, this is a problem. Was that it?
I was affirming that.
Okay. Very few faces on the screen, and so I was able to see your reaction. Let me be frank, I'm not actually the Medicaid queen, right? So it's an area that I, from a preventive health services, because that's hardcore public health, have been engaged in. Been doing a lot of work in access to, you know, or reimbursement for doula care in that space, particularly culturally competent doula care. But I don't, you know, that's not kind of the space that I'm in. However, I have heard what you're saying, so I don't think you're making that up. And it's certainly kind of looking at whether other states, how they might be managing this particular issue. I can put some students to take a look on it. I actually have some colleagues who used to be part of our network but aren't anymore at the National Health Law Program, and they are Medicaid experts. And so I don't mind spending a little time poking around about that question, Chris.
Great. Thank you, Matt.
Kat, thank you. This is really a great update on what's happening, what has happened. I was disheartened to see that they didn't pass a community health worker appreciation day. I'm more concerned about reimbursement for community health workers.
Yeah.
I know that's not your area. You said that's not your area, but have you seen anything about getting them reimbursement? Because they are truly a link between the health departments and the community. And we've had a very robust, active program that is threatened now because of lack of funding for that particular group. And I think they really are connected to the social determinants of health. for many, many, many residents.
I mean, I could not agree with you more. So, community health workers actually kind of surged during pandemic because we needed to meet people where they were because they couldn't go to where they were otherwise regularly receiving services. Community health workers were really great in lots of states at helping people get over the hurdle as to whether to take the vaccination for COVID and for people to get their children regularly vaccinated for even the standard childhood vaccination. So, and there is, again, there's actually a lot of literature in the space of the value and impact of community health workers in communities ravaged by structural racism. And so the reimbursement part is actually, that is a bit more in my space in the sense that that is one of the ways that we know that we can increase access to care. And typically for I try to be careful about my language. It's not folks who are under MDs, but health professionals that are not MDs. Allowing them to practice to the full extent of their kind of education and training, but also being able to be reimbursed. So for some folks, it is like being able to be reimbursed, whether it's a midwife or sorry, my dog somebody decided to ring my doorbell and my dog is barking, so you can tell I'm working from home. In any case, sorry, let me just let him out of my office. I feel so much safer if that 39 people is going to protect me. In any case, he literally was dead asleep the whole time we were talking. So I do know there are some resources out there on this. So let me see what I can gather out there, Matt. And if that's, that can trigger more conversation or there's specific stuff for Maryland for us to take a look at, let's do that. Yeah.
This is an example of like, if we could wrangle the Medicaid contracts, we could get the MCOs to pay.
Yeah.
Like it's like, where are we going to get the money to do this? And the general fund, the general state budget is going in the opposite direction.
Oh yeah.
So
But Medicare does already reimburse for, I think it's a global fee, but they do reimburse for Medicare to.
Care. Yeah.
Not Medicaid.
Yeah.
But either way, Medicare and Medicaid both in your bit of the work you're doing.
Yeah.
Yeah, again, I'm happy. I'll report back. I'll let Shane know when I feel like I have stuff to share and share it out. But also, folks can reach out to me directly if there's more nuance to anything that you want me to look at.
Thank you.
Great. Any other questions in the room, Tosin?
Yeah, just similarly, just frustrated with the fact that, there were not a lot of legislation that supported the workforce in 2024. But again, we have an opportunity to act on that. My question is, have you seen any bill, or did you maybe in recent years see any bill around promoting Public Health Information Act? Because I know some states, have done something similar, which allows, programs and activities within the states to communicate and disseminate evidence-based health information, right? So is there anything around, especially we have a communication and public engagement work group. So I think it would be important to see if there are any legislations around it. Thanks.
Yeah. And what's funny is the panel that's going to come. So I talked about kind of the organizational capabilities, governance, whatever stuff. And then we're going to have funding, workforce, and data on the next panel. And the one thing I didn't have is somebody on communications, right? And I recognize that I just didn't have someone to pull in that space. And I think the answer is to your primary question is there legislation out there? No. There has been work in health literacy space. So the state has passed legislation in the last couple of years to support the concept of building the community's health literacy. I don't know if we could tag on to that or some, so on that one, I'll say after session, can we talk? Because I can only do so much before, but maybe after session talk and let's take a look at what's been done in health literacy, because it's been a lot actually. I've been involved in that on our campus. And so maybe there's a way for us to explore a public health kind of branch of that health literacy concept.
I think it's very important, especially in this age and with the political climate, to set that precedent, especially the legal precedents that there's this authority that can put for accurate evidence-based scientific information. And they are not gonna be dinged for that.
Yeah.
Right?
I mean, look, we're fighting misinformation and disinformation every day in this space, and it will get worse.
Thank you.
Great. Kathy will be back after for another session. And so let's save any other further questions for Kathy as we do question those individuals as well. Kathy, thank you so much for this
You're welcome.
presentation. In particular, you know, I do want to sort of emphasize the importance of us working together with the Legal Resource Center for Public Health Policy in this next year as we, you know, come up not only with the recommendations, but for us to have your expertise and your team's expertise to see how do we focus on what are the legislative changes that we will recommend, right? I mean, part of the pathway is going to be working through the General Assembly, and I'm really excited about having that partnership with you. What we're going to do now is take a 7-minute break until 3:25. That's 3:25 or 15:25 if you prefer using that system of time telling, which I'm a big fan of. I'm a 24-hour clock person, so 15:25 we will regroup. Those of you on the internet sites, feel free to stretch a little bit. We're going to have some snacks here, so I wish you were here.
I didn't look in the slide, but on the slide, Kathy's slides, she posted the link to the trailer, all of the
track?
questions, especially the HR questions, are pretty detailed. So that's, yeah, when you're getting numbers, you got to pull data. You got to get the data. If you don't own the data, you got to.
Okay, welcome everybody. And we'll be beginning in about 1 minute. So please get your seats. Those of you in the world of the big screen, get ready for the second half of our meeting. And there's certainly a lot to be discussed. Just as a reminder, we'll have commission updates. We'll then have the policy panel, and we'll have some guests that I'll be introducing. And then beforehand, we'll have a further discussion about some of the points raised in terms of potential hearings and testimony, and looking whether we can come up with a consensus statement on the commission's approach. We'll review about that, and then announcements, and then we'll close. Our next component of our agenda is commission updates. I'll ask Shane to give our general updates. I do want to remind the group that from a commissioner's perspective, I realized that sometimes dealing with the commission is like dealing with a proverbial elephant. Depending on what you're looking at or touching, you see the tusk, you see the leg, you see the tail. The commission is all of that and more. And a lot of these updates are not only what's going on at the commission level, our monthly meetings, but in essence is the approaches from our most incredible work groups that exist out there, and the co-chairs of those work groups, and the incredible work that, we permeated into an incredible number of volunteers who are running this commission at the work group level, at the staff level, as I mentioned earlier, at the work group co-chair level, at the commissioner level. We're also holding special executive sessions every Wednesday morning of the co-chairs and the staff. And then we're holding intermittent afternoon sessions on Wednesday with, for example, the commission, with the co-chairs and the work group chairs, as well as monthly meetings with the representatives from the Maryland Department of Health, Nilesh and Vanessa, and then also intermittently holding a meeting with the Secretary of Health. And so there's a lot going on. And so Shane will update a little bit on where we're heading in many of those different directions. So Shane, thank you.
Great. Thank you, Boris. Next slide. So I shared with most of you already a full update of the timeline. And we told you at the last meeting that we were reworking the schedule based on how the experience with the interim report went, and understanding that that was really just a small slice of what the final report would look like. And so we wanted to make sure we had enough time to build in enough review and conversation around that. But we also recognized that as we started talking about the process for drafting recommendations and what would be required for that, that we needed to change the approach there. So previously we had talked about having the recommendations really be presented kind of en masse by work group, similar to the deep dives that we did. And the reality is, based on what we're starting to see come out of the assessment findings, as well as really where each of the work groups are based on the work that they've done so far, is that we need to have more of a rolling format for that. And so we developed a framework and shared that at our last leadership meeting, I believe it was a week ago or 2 weeks ago at this point. And I included some of that information in the updates to you by email, but essentially creating this process where we'll be able to receive recommendations as they are drafted and ready to go, which necessitated us adding in 2 additional meetings to the calendar, which should be on your calendar now. I sent those out this morning, but April 15th and May 20th are the 2 additional dates to make sure that we've got enough time to review, discuss, and vote on all those recommendations. And as with all of our planning, if it turns out we don't end up needing all of those meetings, we'll revisit that. But we figured it was easier to add now and remove later than try and last minute. In that vein, we took very seriously your feedback about making sure we were making the most of our time together, and so we were really thoughtful about the final speakers that we invite. And so you'll see next month we do have the Maryland Department of Environment Secretary speaking, and we are working on getting John Auerbach to one of the April meetings. And then we're coordinating or getting ready to invite the DBM secretary as well. Those folks really represent kind of the final stretch of people that we think could help inform this conversation. And in particular, noting that the 2 secretary invitations kind of track back to the statute or some of the conversations that have come up through the assessment findings or site visits in terms of understanding the landscape. So I wanted to acknowledge that we heard you about being thoughtful with the time together. So all the stuff in red here represents changes or new things. And of course, this is just a half the year presentation. We've got the full calendar that's been sent to you. So I would encourage you to please take a look at that and let us know if we've missed something or if you think that some of that is unworkable. But essentially, it's going to be a fast clip between now and May to get the recommendations together, and essentially in a good place so that we can post those around June 5th or so in order to meet that 30-day posting requirement for public comment. So that's kind of the biggest piece there that I wanted to highlight, and of course mentioning those 2 additional dates. Next slide.
Did we extend the invitation to Laura to come back? I know she said she wanted to come back.
Yes, we're working with her team on getting a time set up for that. One of the challenges right now has been with session and trying to honor that. So it'll probably be closer towards the end of session or after session, but that is on the horizon. In the meantime, the co-chairs have been keeping in touch with her. I think quarterly, is that right?
Just about every 2 to 3 months, yeah.
So I spoke through most of this already, just in kind of general terms, but specific to the recommendation framework, I wanted to highlight that we're kind of thinking through these in a couple different buckets. We know that statutorily there are requirements for what a recommendation must contain. For example, it has to be resultant from the assessment, so the demonstration of a need. It also has to connect back to a foundational public health service and have demonstration of how it will improve that. And that's language directly from the statute. So knowing that, there are pieces of this work that may not rise to the level of being a recommendation, but it's still important, right? I mean, there's been a lot of time and effort put into exploring and assessing the state and local public health system here. So we want to make sure that we're capturing those pieces that maybe aren't quite ready for recommendation level, and making sure that they're documented for future work in this space, assuming that there may be other commissions or groups that come behind us. That would be a great place for them to start. And so we're kind of calling that areas for future inquiry or future exploration. And so we assume that each work group would have some content or thought to add there, whether that's an emerging practice or something that we just didn't have enough time to get to consensus on. We think the recommendations naturally will come together thematically in some ways, and might be bucketed under kind of strategic priorities that would help serve as a way of uniting these themes together. And to the point about discussing or publishing briefs, when we get to that point in October, we think that the strategic priorities and that grouping would be a great way for us to kind of group those. And so we wanted to float that out there as an idea for folks to consider as kind of a level above recommendations to help us kind of think through what is it that we're trying to accomplish, what is this longer term outcome. And at this point, we are starting to think through the final report outline based on obviously conversations with you, but also what we went through with the interim report. So as you have thoughts or there are pieces that you think you definitely want to see in that, we welcome that feedback from you. Next slide. On the assessment front, we had a great steering committee update today. They have gone through 73 interviews, and I think there were maybe 90 individuals we identified for them to reach out to. So a pretty good response rate there. The lingering folks are mostly individuals that are, I think, Tashanka, they were the stakeholder group, not necessarily the key informants that we were looking for. Not ideal, but at the same time, I think this response rate really does represent one that we've reached all the people that, you know, statutorily we thought we needed to, but also just overall that it's, you know, north of 80% response rate, which is pretty unheard of in this type of work. Additionally, there are 12 focus groups, and that represents all of the focus groups that they were slated to conduct. Those are finished. And so they're working through the analysis of those right now. And then we do have the organization surveys for local health departments and MDH due at the end of the month, which will round out that primary data collection piece. We also have finally secured the data use agreement with NACCHO to get forces of change and local health department profile information, which will supplement what we've collected. And that will be useful for both us as well as some of the work that NACCHO and De Beaumont Foundation are doing as well. And so where this goes next is the 19th of February, the work group co-chairs at that leadership call will get a briefing on what the assessment team has kind of analyzed and discovered, and hoping to get workshops scheduled for the work groups in March to really talk through some of those cross-cutting recommendations and areas that need to maybe have coordinated approach on crafting a recommendation. So more to come on that, but wanted to make sure that was on your radars. Okay, next slide. All right. One of the things that we've heard from several commissioners, as well as some of the work groups as they were working through their deep dive preparation and even starting to talk about how they calibrate themselves for crafting recommendations, is getting a sense or understanding of what is it that we're trying to do, what is our goal here. And so with that, we spent some time over the past 8 weeks or so with the commission co-chairs to try and get a sense of where their priorities and interests were with respect to the commission, and putting together some of those thoughts in a way that might help express some of that. And so what we wanted to do is, now that this is in a somewhat polished place, share this with the commission as a whole to get a sense of, does this represent what you hoped the commission would do, or what you hope to see for the state of Maryland? And in that vein, what might be missing, or maybe what is too prescriptive here, knowing that these will kind of serve as a North Star for the work of the work groups. I recognize we're a little pressed on time today, so I don't expect that we'll get to a full place of consensus, but I wanted to highlight them so that we could start to have that conversation with a goal of maybe getting to a final place by the February meeting. And so we do have vision mission statements here, and those were sent out to you by email as well. And then on the next slide, we have some value statements that we hope expresses kind of the work that we've done to date, as well as the work we hope to continue doing particularly around those areas of inclusion, health equity, communication, and innovation. So we think that in sum total, these come together, these three statements, mission, vision, and values, to accurately represent the work in a way that gives a clear sense of direction without being too prescriptive about how each of the work groups do that. I will concede that even in the conversation with our co-chairs, there were different schools of thoughts about what these should be. So if you feel like this doesn't quite hit the mark, you're probably not alone. But at the end of the day, we wanted to get something in front of you to start that conversation. So we'll be happy to have more conversations with you about that, either offline or before the next meeting. Next slide. All right. Last but not least on my end, I do want to give a great shout out to the St. Mary's County Health Department team for again hosting and providing all the communications resources for us that they have to date, and to also acknowledge the MDH Web Services team for helping us get this new website stood up, and it is now live. And so after this meeting, the old address that you've been using is going to redirect you to this one. And we are officially a Maryland.gov website. So update your references as needed, and thanks for helping make this possible.
Great, thank you, Shane. Any questions, clarifications for Shane? So my point on the vision and mission statements and other things submitted to you is, please look them over. Do provide email comments directly back to Shane or to us, the executive committee, the commissioners, but Shane will be the main point on that, and then we'll have further discussions and bring it up for a vote at the next meeting. So please look at that and put some due diligence into looking at those statements.
I just have
Yeah, go on.
formatting question
Yes, Brian.
about the about the commission segment. Is clear that that's to be like, that's sort of like the tagline on any of our publications or communications. Where do you see these other elements? Or is this just for us, or is this to be like, where is this going to be going?
I would certainly like to make sure it's on our website for reference, certainly distributed to the work groups so that they have it for kind of helping guide the development of some of those recommendations, and then ultimately in the final report somewhere, whether that's an appendix or what have you.
Okay, I got it. So this is like for all time. These are statements.
Yeah.
Just in the last several days, I've been reflecting on some developments nationally, and so this doesn't speak to that. This is very much into this. This is describing us, and maybe by the time the report is released, some of the dust will have settled around this chaos that's going on right now. But if it hasn't, or if there's continuing threads of anxiety, I think that in addition to this, there could be some more language here that would directly address the value in terms of health equity, of diversity, equity, and inclusion. We could express a deference to science and our leading federal partner, which is CDC, okay? And we could support the continuation of federal health programs that are essential to communities, particularly low-income communities, and particularly for those Medicaid enrollees who are pregnant or who are newborn. So I'm trying to get at some public health concerns that have been lifted up this week. And I think it's in our wheelhouse to make some cogent statements about that. Not now. This is all like a lot of drama right now. But when we have some time to look at what is really likely to take place, or the shape of those things. Mm-hmm. I think that as important as this is, to be more direct with where we believe policy should go is also something we should not leave that opportunity.
And point well taken, Fran. I think two things that I'd like to say about this. One of which is this discussion as we were formulating and drafting this and multiple drafts from the executive committee level is it was done before, as you sort of said, the events of it. But at the same time, what I would push for is for us to, to ratify these, post these, get these on. But the final version, the way I look at it, the final version is what we put into the final report. And I think what we'll be able to do is begin looking at this idea of what has transformed, not be too reactionary at this stage, but at the right time, right, when in essence, as we're saying our final statement as a commission, that we be bold in our approaches, saying, okay, we've been through these metamorphoses, for want of a better term, and here is what we're in essence observing, and here's the comments on these observations, and whether it's support of our federal partners, right, how it all applies to the health, to the public health of the state of Maryland is a critical piece, and I think there's going to be things that will be changed with time.
Right. I fully agree.
Any other comments, questions on this before we move on?
Just, I mean,
Yeah.
I would argue we should be focused on outcomes. So, I mean, this says equitable access to comprehensive public health services. Services are an activity. I think really we should be focused on, sort of the mission is healthier Marylanders, as measurably healthy, healthier Marylanders. And
Right.
So not the services.
Okay. We'll take that point. Great, thank you all. Thank you, Shane, for that. I also want to acknowledge before we go to our panel discussion that we do have a guest here, and it's Angie Truesdale. And she's the Director of Public Health within the state of.
No, we're a vendor of the state of Massachusetts, working to support them in their public health transformation, which includes FPHS implementation as well. So we've done a lot of this capacity work and all from Massachusetts. Learning a great deal from all of you.
Good. Tell Massachusetts they can learn from Maryland.
Yeah.
So anyhow, thank you so much for being here, and we're willing to share everything we've learned. As you know, as part of the metamorphosis is we've co-opted a bunch of people from India, or at least Shane from Indiana, who was involved in that approach. So it's almost we're in a constant mode of improving of what came before us, and then sharing our aspirations with those who are coming after us. So thank you.
Raised her hand.
Now, I'm sorry, there's a hand raised.
Jean Drummond raised her hand.
Okay,
Yeah.
Jean.
Hey, happy New Year to everyone. I was going to say back to my other colleague who mentioned about, making sure that we're focused on outcomes. So just recently, the Maryland Health Cost Commission also really emphatically, continually in that document speaks to not just focusing on the quantity and quality, but how outcomes. So that's really important that we align with not only that, but NCQA and just, and even in the outcomes, there's back to the health equity piece, we can speak to those measures. So I just kind of wanted to say that would certainly keep us in alignment with other documents that are, that are already out there.
Great. Those are great comments, both.
If there's any way we could get some sort of, in addition to the legislative briefing, a briefing on especially what's happening with the Health Equity Commission and the HED stuff, it's just it's relevant to what, and like the more we can echo some of this stuff, as long as we agree.
Yeah.
It's probably good. I don't know whether our interns have access to that stuff or through the through our State Department partners, we can get access.
We'll find a way. Thank you, Gene.
Can I make one?
Yeah, go on, Matt.
And maybe we can come back to this, but I'm sort of reading the draft vision and mission, and again, and in my experience, the vision is really your penultimate, and it's not guided by a goal. Your vision is, that's the goal. That's the end result. In the way I look at it, just my one person's opinion. So, the commission's job is really, I think, or it sounds like the commission's job is really to create recommendations for a system of public health that is efficient, effective, and data-driven and evidence-based that drives positive health outcomes for all Marylanders. So
Improving outcomes, yeah.
yeah,
100%.
driving improved outcomes. So to me, it sort of doesn't quite get there. Just my 2 cents on it.
Good. So we would provide those, we'll take your verbal right now, but if there's any other modifications, please send them on and we'll get a comment version from all 16 people, right? I mean, I don't want to get into wordsmithing at this point, right? It's hard, but at some point, I think all of you have made a good point. And so, you know, let's make sure that's reflected in our final version, or at least final at this stage, taking Fran's comments into effect. Any other comments on this?
I think for time we can move on.
Great.
Rosalie's hand has been raised for a bit.
Hi, this is Rosalie Bray. I wanted to comment on something a little bit different. The issue that was brought up maybe 5 minutes ago about how the federal functions are in chaos. I read that the CDC is not allowed to communicate with anybody outside CDC at least until February 1st. And that's when we've got issues with avian flu in the Delmarva Peninsula. I'm really worried about this, and I think that it would be useful to have a little side pivot around what should the state do if the federal public health agencies aren't there for us. Like, you know, we've relied on CDC to report back to everybody our own state data. Do we have a plan to report the data ourselves?
Yeah, we can certainly have those discussions both with the Maryland Department of Health representatives on this committee. I mean, you know, the reality is public health at the Maryland level still continues to function and is able to communicate with its population, for want of a better term. The question that you have, Rosalie, and one that, you know, is ultimately, you know, we certainly as a commission can turn to our friends, you know, and fellow commissioners on this commission who are dealing with this and make sure that they are supported in terms of making sure they have a flow of information that's critical to the state of Maryland. But that's a very good point, Rosalie. Thank you.
Yeah, and I also wonder whether states need to think about picking up the work that CDC used to do. And maybe one way to spread the load is to work with other states to do that.
Yeah, understood.
Yeah, thank you.
Anybody else on that, Tommy? Thank you.
Do we have does the CDC we have a channel to the CDC Foundation? I just wonder if we can get some.
Is there any word from the CDC Foundation on this? I know this is all late breaking news, so the question is, but that we do have connectivity, right? I mean, we have a close partnership. So let us monitor what we can do with the CDC Foundation on this. That's a good point, Chris.
We just might have time.
Yeah. Okay, I'm going to get to our panel discussion right now. We're very excited. Kathy will be back. We heard about Kathy. We have Stephen Murphy joining us. He's a public health attorney, director of the Mid-States region of the Network for Public Health Law. His work has been on public health data exchange, access and sharing, data modernization, and public health authority. He used to work as an attorney for the Chicago Department of Public Health, Go Cubs, concentrating on public health data privacy and public health law, was legal counsel to the Office of the Commissioner and served as the City of Chicago HIPAA privacy officer. We're also pleased to welcome Andy Baker White. He's the Senior Director of State Health Policy for ASTO, the Association of State and Territorial Health Officials, oversees tracking, analysis, dissemination of legislative and regulatory trends, responds to requests for legal technical assistance, conducts legal research and analysis, and collaborates with ASTO's programmatic teams and partners. He has his public health degree, MPH from the University of Washington, and his law and Bachelor of Arts degrees from the University of Kentucky. And then finally, we have Katie Ellis Hiltz, assistant professor in the Department of Health Policy and Management with the Richard M. Fairbanks School of Public Health, got her MPH in Social and Behavioral Sciences, followed by her PhD in Health Policy and Management. Finished up an NIH postdoc fellowship in behavioral oncology, and prior to her academic career, spent 8 years working with the Marion County Public Health Department in Indianapolis, most of those years in tobacco control programs. She's also co-authored a 2022 Indiana Local Health Department Workforce Assessment and a related article conducting a comprehensive assessment of the public health workforce, lessons learned, and opportunities for the future. So thank you all for being here, and Kathy, take it away.
If I take it away, I'm taking it away to Stephen. So I just want to thank Stephen, Andy, and Katie for joining us today and doing a great job. So be nice to them, my Maryland friends. Take it away, Stephen.
Thanks so much, Kathy, and thanks everybody for having me this afternoon. It's a pleasure to talk to you guys. And Kathy, I'm very grateful for the invitation to talk. This afternoon, I wanted to chat about a project outside of Maryland in the Chicago area that we have been working on, and that is off to a very good start. It's a data sharing project that involves a community information exchange. And I will talk a little bit more about what community information exchanges are. But, big picture is that they're a network of health and social service organizations that come together to create a shared governance and data exchange and some other good things to improve services that are offered to members of the community. And so the Network for Public Health Law was engaged to work on a legal framework around the community information exchange. And so that's what I want to share with you this afternoon, is just some successful data sharing initiatives outside of Maryland that some considerable law and policy analysis. Can we go to the next slide, please? So just a quick disclaimer before I get started. I am an attorney, but I am required to tell you that I am not a last year attorney. And so please don't interpret anything that I say this afternoon to be legal advice. And if you do have legal questions, please consult your own counsel. And similarly, my talk this afternoon should not be considered to establish an attorney-client relationship. Let's go to the next slide, please. So with that out of the way, I'll just mention that the Network for Public Health Law, for those of you that are not familiar with us, we are a national organization, a not-for-profit, that provides services, legal technical assistance and resources and other good things to state, tribal, local, and territorial health departments, to public health practitioners and officials and policymakers, and community-based organizations as well that need our help. And I would encourage any of you to reach out to the network if you do have public health related legal questions that you need assistance with. Next slide, please. So with that said, I'll just dig into this community information exchange material. And again, a community information exchange is a network of health and social service organizations and agencies that develop shared governance to support the needs of community members. So this really brings together both health and social services, and it involves sharing information amongst different participants in the community information exchange, including hospitals and FQHCs and shelter providers as well. And that has traditionally been a sticking point for exchange of data. We're all familiar with HIPAA to some degree, and although in our case to a great degree, but there are parts of HIPAA that make clear that HIPAA does not get in the way of payment, treatment, and healthcare operations. But applying that outside the context of healthcare has been tricky in the past, and there are perceived barriers, and in some cases, actual barriers, legal barriers to sharing the data. And so that's why we were brought into this project. Let's go to the next slide, please. Just a little bit more on CIE. So they serve as a care management hub, allowing participating providers to deliver more responsive, more effective community care planning for people who face multiple, often related challenges. And you see some examples on the screen there of food insecurity, unstable housing, and access to healthcare. And these CIEs have been popping up around the country with some great success. San Diego is actually a good example of one that is something of a model for other parts of the country, and involve, including the model in Chicago, the first use cases are around homelessness. And in Chicago, they will specifically be respite care for folks coming out of hospital who are not housed, but nevertheless need more care before they move on. And then also shelter-based care, so providers in shelter settings that provide care to individuals. And so those are the two use cases on which the CIE will focus. Let's go to the next slide, please. And so we were tasked with developing a legal framework around a community information exchange. And so, because we don't provide legal advice, really, we're looking at this community information exchange model in general, and looking at the different bells and whistles that are involved. And specifically, we were involved in the exchange of data and how that exchange will work, and really kind of going, looking at Illinois law and just basically trying to figure out, hey, can we even do this? But with any data sharing activity, we tend to put our thoughts into this structure that you see on the screen here. This is from the Pathways to Yes, which is a resource that the network developed with DASH, which is Data Across Sectors for Health, which is an initiative of the Illinois Public Health Institute. And actually, I should have mentioned at the beginning that the Community Information Exchange is a project of the City of Chicago and the Cook County Bureau of Economic Development. And they have engaged the Illinois Public Health Institute to develop the CIE. So in any event, you see on the screen here then this kind of structured approach to data sharing initiatives, including reviewing relationships, both internal and external, developing a use case that's really a narrative description of the entire project as it relates to data sharing, and what the different bells and whistles are, who's going to be involved, and what the data elements are going to be involved, etc. And then similarly, a data flow map really maps out where the data is starting and ending, and where it's going everywhere in between, who's going to have access to it, where it's encrypted, where it's not encrypted, where it's identifiable, etc., etc. And then where we tend to focus is really on these last two steps, and where we tend to be engaged is really around the legal analysis, and then establishing terms of sharing that is really relating to data sharing agreements or data use agreements. And so that's kind of where we will focus today, is really on this legal piece around a legal framework. Let's go to the next slide, please. So we had some goals for the work that we did around the community information exchange, and chief among them was to facilitate the exchange of data, again, between these different participants in the community information exchange, which again are likely to be hospitals in the Chicago area and federally qualified health centers, and then also shelter providers as well. And so that's really chief among the goals, is to facilitate this data exchange. But of course, data protection is another very important goal that we have to prioritize as well, because we want the data to be protected. We want the integrity and confidentiality and availability of the data to be protected, and so that individuals' information, which will be individual level information, will be protected according to the law and according to our expectations in terms of privacy generally. Transparency and accountability was another goal. Really there, it's important to get buy-in from the participants in a community information exchange and from the individuals whose information may be exchanged through the community information exchange. And so that transparency and accountability is really about being transparent about, at least from our perspective and the work that we were doing around how the data will be handled and who will have access to it, etc. Consent is another big piece of community information exchanges, and that is also the case in the model in Chicago. The entire community information exchange is built on consent of the individual, this robust consent where the individual consents to participate in the CIE, consents to have their information shared among participants where necessary. And if they do not consent, then their information is simply not shared through CIE. Let's go to the next slide, please. I'll talk a little bit more about consent in just a moment. But so please don't be overwhelmed by this slide. I gave a similar talk last week to some folks who told me afterwards that the number of agreements in different parts of the legal framework were a little overwhelming. So I will try to go through these, but I do want to just stress that, particularly as we talk about different agreements that are involved in a community information exchange, not all participants will be required to agree to all of the agreements. And so the, again, cornerstone of the legal framework around a community information exchange typically is around consent. And again, the individual will consent to their own information being exchanged through the community information exchange between healthcare providers and other social service providers that are engaged in the community and providing services. A notice of privacy practices is another important element. That's a requirement of HIPAA, but in the context of data sharing, generally, it's not a bad idea for other entities that are not subject to HIPAA to have a notice of privacy practices, even where not required by law. And then there are several agreements that are involved in the community information exchange, which I'll talk a little bit more about in just a second, but those are the participation agreement, and there's a business associate agreement that complies with HIPAA, and then a data use agreement as well. And then there's this master services agreement, which is likely to be involved in a CIE to the extent that there may be a platform, a technology platform for sharing information. And, just as we have terms of service with our phones, with different applications on our phones, similarly, the host of a technology platform may well have terms and conditions as well. And then policies and procedures. So having policies and procedures around how the data is used and shared is important as well. Let's go to the next slide, please. So I have just a few more pieces about consent because it is, again, this cornerstone of community information exchange. It provides this legal basis. As privacy attorneys, typically consent is the gold standard. If we can get consent from the individual to use their information, that is golden. Now, that's not always the case. That sometimes it's impractical to get the consent of individuals. If you think of, for example, a large research study that has 20,000 participants, it's not always practical to get consent of individuals to have their information shared. But that also goes to the autonomy. This kind of goes back to the transparency piece that I was talking about as well. That this consent of the individual also allows the individual to exercise their autonomy over their own information and how that is used or disclosed, and building trust, again, from individuals and from other participants in a CIE, because ultimately you do need buy-in from participants and from individuals to make the whole thing work. And then this clear guidance on permissible use of data. It also includes permissible disclosures of data, but that consent piece too, if the individual is consenting to the release of their information or the exchange of their information and the specific types of information that they are consenting to release, that's also another benefit of consent. Next slide, please. So I mentioned there's several agreements. I won't go into these in too great detail just because of the time constraints that we have this afternoon, but again, not all of the participants are required to agree to all of the different agreements. Participation agreement does apply to all participants, and that really is kind of a level setting agreement that speaks to participation and use of the community information exchange and the different types of information that might be shared and the types of information that might not be shared. There are several types of information that have elevated privacy protections, like HIV or STI information or domestic violence information in many jurisdictions that has elevated privacy protections. And so that may not be always the case that could be shared through the CIE. Business associate agreement, again, is a HIPAA requirement. So those entities that are subject to HIPAA would have to execute that. And then the data use agreement that is in place often to make up for a business associate agreement for those entities that are not subject to HIPAA, but nevertheless need to have some additional requirements with respect to data. Next slide, please. So this, I think, is my last slide. So, but I am cognizant of the time. So we'll go through this a little bit quickly. But, in terms of thinking about the legal considerations around a community information exchange and policy considerations as well, there are certain authorities that have to be considered and have to be granted to certain entities within the CIE. There's this concept of a CIE backbone entity, and that really is an organization or entity that drives the development and implementation and maintenance of the CIE. And so in order to make this all work, we envision that a backbone entity in the CIE should be granted authority, typically in the context of a business associate agreement, to do certain things like what you see on the screen here, including managing requests for protected health information or maintaining a community data repository. That's a longitudinal record for individuals whose information is shared through the CIE. And this is a big feature of many community information exchanges, to ensure that individuals do not have to retell their story and relive trauma every time they go to a new service provider. And so this longitudinal record then would provide this ability to generate this record and add to the record over time as individuals interact with different service providers and healthcare providers. Other authorities include the ability to release protected health information from the longitudinal record or to operate a master patient index. I won't go into really what that is about, but really it's about avoiding duplication of records and some other things. Authority to standardize data formats as well, and then there's just some other authorities that are mentioned here to facilitate the identification and correction of errors in records or provide record locator or patient matching services as well. So those are just some of the legal considerations and the legal authorities that have to be considered in the context of a CIE. Next slide, please. So you see on the screen here just a link to more information about the Chicago region-wide community information exchange and the different partners that are involved in that. And that URL you see on the screen there, Chicago region-wide CIE, has some great information. Next slide, please. But I do want to mention also just the network's website, which has many resources authored by my great colleagues, including Kathy. And so you can check out our website at networkforphl.org, where you can find written resources and blogs and fact sheets and information about future webinars and past recordings of past webinars. All that is available on our website, and I encourage you to check it out. And then I think the next slide is just a Q&A slide. I don't know, Kathy, if you want to hold off on Q&A maybe until the end of the panel.
Yeah, let's do that. I think Andy's up next.
Great, thanks.
Just in the interest of time, so we know then how much time there is for Q&A. Take it away, Andy.
Yeah, hi. Thanks, Kathy. Hi, everyone. Thank you so much for inviting me today. Again, my name is Andy Baker-White. I am the Senior Director for State Health Policy at the Association of State and Territorial Health Officials. We go to the next slide. So just some information about ASTO. We are a member organization for the chief health officials for each of the U.S. states, territories. That includes the District of Columbia, as well as our island jurisdictions, both the territories and the freely associated states. Our mission is to support, equip, and advocate for our members as they work to advance the public's health and well-being. So technically we have 59 members because there are only 59 jurisdictions that meet that requirement. But we do a lot of work in providing them with technical assistance on all the issues that they come across. And one of those issues here recently is we got a couple of requests from our members kind of really wanting to know how local health departments are funded across the country, and really what the role of their agencies and the states are in that funding. So if you can go to the next slide. So one of my colleagues here at ASTO, Maggie Davis, who I believe is a University of Maryland grad, she dug into this question, and she looked at the statutes, at the policies at the state level to really see and get a picture of how our members, our state health departments, take a role in funding the local health departments. So she put together a report. I'll put a link to that report in the chat when I'm done. But she came across some pretty interesting findings, and it really helped us be able to kind of look and see, what are those different mechanisms, what are some of the conditions that are put on local health agency funding, and then kind of like how are those levels of funding really determined. All right, thank you. I see that the resource was put into the chat. So we started looking at our members. Again, actually we focused on the states, so we didn't look at DC or the territories or our freely associated states. And 15 of our members are characterized as being centralized jurisdictions. So that means that all the health services public health services are actually coming from basically the state. They don't have local health agency components. So we didn't look necessarily at those jurisdictions because there was really no local public health departments to fund. Of the remaining jurisdictions, 27 of them are characterized as being decentralized. So there's a state health agency, and then there are multiple local health agencies below the state. And so they work together to provide public health services across the jurisdiction. 5 of the jurisdictions are considered mixed, and that's kind of a mix of both centralized and decentralized. And then 3 are characterized as shared, where we look at those and and they are jurisdictions where the provision of public health services is shared by local and state health agencies in some way. It can be tricky to categorize the different governance structures across the states because every state is different. But we try our best, and those have been the categories that we've used in our annual report on the status of our members that we've used for quite a while. So those were those 35, I believe, jurisdictions were the ones that we took a look at. And in 24 of those, we actually found statutory requirements for the state health agency to provide funding to the local health department. 20 of those were in decentralized jurisdictions, 2 were in mixed jurisdictions, and 2 are in shared. And what we're looking at when we're looking for quote unquote legal requirement to fund were different mechanisms of like direct funding. So the state health agency provides direct funds to the local health agencies, or reimbursement. So the local health department spends funds and then can get reimbursed by the state health agency, or grants, so that the local health department has to actually apply for an amount of funding from the state health agency. We didn't include provisions where there may be a statute that says that a certain type of public health program is established and the state will provide X amount of funding to the locals. And we didn't look at statutes where there may be an allocation to a local health department that might come from a special state fund that might be controlled by the auditor or the treasurer or some other agency at the state level. So we're really focused on ways that the state health agency provides funding or controls the funding for local health agencies. So of the 24 jurisdictions that we found that had legal statutory requirements, we found that 14 of those actually provide direct funding to the local health departments. 8 of them actually have grants. So the local health departments in some way have to apply to get the funding. And then 2 of those, 2 of the 24 have mechanisms around that are reimbursement. So the local health department spends and then can be reimbursed by the state health agency. What we also found, we looked at and we started finding that states also set conditions on the local health departments in order to be able to receive the funding from the health agency. And these conditions, they varied, but they fell into a few different buckets. One of the most prevalent kind of condition was that the local health department meets some sort of standard or meets the minimum core services for public health, or that they are in compliance with agency rules and agency standards. So that was one category. Another category that, as far as conditions for funding, that we saw were that local health agencies make some sort of minimum contribution to the services, and then that the local health or the state health agency can either match those, or once the local health department meets those minimum contributions, then they qualify for additional funding. And then a couple other kind of conditions that we saw on local health departments for funding. A few states have requirements that local health departments provide either a budgeting information, like how the money would be spent, or financial statements, or some sort of expenditure plan. So I can see, so the state health agency is having some sort of oversight of how the money is being planned to be spent. And then finally, what we saw were just some requirements that the local health department provide a work plan. So it's maybe similar to a financial statement, but I think more of kind of how the programmatic work would be, or also making reports either to the health agency or actually to the legislature about core services and so forth. And then so the final thing that we saw was like, okay, so we know the mechanism is going to be either direct funding or grant or reimbursement. We see the conditions that the local health department needs to meet. And then so finally, the question that we saw or that we had was, so how are the levels of funding determined? And we saw a few categories of that. Most of the states use a formula to determine the funding level. And a lot of times the formula is based upon the population as well as the disease burden within the local health department jurisdiction. And then the other level of determination way to determine the funding level was just on a flat per capita basis. So just so not necessarily kind of looking at what the burden is within that local jurisdiction. And then we found a smattering of a few that just kind of do it on their own. For example, Washington State actually, under their recent legislation, they require that there's a group consensus among the state, locals, and tribal health departments as to what the funding levels would be. And then there are some states that have a really strict reimbursement determination, and then also some states that use kind of a matching determination for their funding level. So that's what we have there. I think, it'd be really great if we could do some next steps. I think to find out like which works best, but we're not quite there yet. And so if that was one of your questions, it's not something I can answer at this point. Maybe we can I can talk to Kathy maybe later on about some, we've provided this information. So maybe some public health researchers can maybe see what the impact of these different categories are in the future. But that's really what I have now. I think we shared the report that I covered, and I'm happy to stick around to answer any questions.
Thank you, Andy. And I love that you preempted the one question you get and can't answer. There you go. But yeah, obviously it's an open issue for research and conversation across the country. So again, in the holding questions until the end, I'm going to turn things over to Katie Hiltz, who's going to speak with you about some workforce issues, really drawn from her work in Indiana. I'd say go Hoosiers. There you go. Take it away, Katie.
Thank you. Sorry, my camera wasn't working, and I may have to turn it off. I've been having some bandwidth issues, but very glad to be here. And I had the privilege of meeting several of you when you came to visit Indiana to kind of learn about what we did here. Great to see some familiar faces and names, and obviously Shane from Indiana as well. So today I'm just going to kind of quickly go through a little bit about the process and some of the lessons we learned during our assessment of the local public health workforce here in Indiana. In preparation for efforts to increase funding, which we were successful in for public health in Indiana. So next slide. So before I get into the meat of this, I do want to acknowledge our team, in particular, Dr. Valerie Yeager, who I co-led this with and who is a national expert in public health workforce research. And so maybe can help you looking at some of those models as well. And just a lot of the other folks that were involved in this had a very extensive group of staff and other researchers and colleagues that were involved in this, and could not have done this without the participation of the local health department administrators and employees throughout the state of Indiana, as well as the support of the Indiana Department of Health and funding from them through the Centers for Disease Control and Prevention that really supported this work and was crucial in helping to inform activities related to increased funding here in Indiana. So next slide. So just to set the stage a little bit of what really drove this and kind of where we were at when we began this assessment. So there is national data, Public Health Wins survey that is collected on employees of governmental public health agencies, but especially in Indiana, and I imagine other places, it does not adequately reflect the local health departments across Indiana. So the 2021 Public Health Wins survey, only 11% of Indiana's responses were from employees outside of Indiana Department of Health, as well as Marion County Public Health Department, which is our largest health department in Indianapolis, Indiana. So really a gap in understanding all of our workforce across the state. Next slide. In addition to that, really bred out of some of the work that Valerie Egger and some of our other colleagues did, the Governor's Public Health Commission in 2022, their report did recommend one of the next steps in strengthening our public health system in Indiana was to collect reliable information about local health departments and the workforce in those health departments. And so that really was what kind of spurred this and led to the Department of Health reaching out to us to conduct this assessment. So next. So as part of this assessment, we looked at multiple things, and there were 4 primary components to our data collection. The first was a workforce assessment of the individual employees of each of the health departments across the state. And so to facilitate data collection, we did create this as an Excel spreadsheet that allowed for each of the health departments to capture all of the different employees in their health departments, including information related to salaries, job description, hours worked, time spent on foundational public health services, both areas. And so we did that one. We also did an organizational survey that was to collect organizational level information about the health departments. And that specifically was looking at issues around recruitment and retention, as well as training needs, and those were completed by local health department administrators. After we collected and kind of synthesized that data from both of those pieces, we did also conduct qualitative interviews with administrators and or local health officers across all of the, a lot of our local health departments in Indiana. So as you can see here, we do say what our response rate was. So we got almost 98% of local health departments in Indiana were represented in our workforce assessment. That equates to about coverage of 99% of our state's population. We had almost 97% of the local health departments respond to the organizational survey, and 70 local health administrators representing 74% of the LHDs. We did also attempt to collect job descriptions and scope of works for different positions when they were available. That was not quite as readily accessible. So next slide. So the process of doing this, we were very intentional about, working with IDOH as well as other representatives from local health departments. Actually, about 4 of us on our research team were all former employees of health departments and have good connections with some of the folks in the state. So we're really fortunate to get good feedback and response from some of the different local health administrators as well on our kind of data collection pieces. So we piloted and got feedback and refined it based on that. We did craft a joint letter between the state health commissioner at the time and our dean, both of which are gone now, but both were really great partners in this. And then we're able to participate in monthly meetings that IDOH held with local health department or department administrators to promote and answer any questions on this. And then also created and disseminated an FAQ and had a kind of opportunity if folks ran into issues to kind of reach out to us and get support through that as well. So next slide. So as a result of this, we were able to capture a lot of data on our employees. We did also have access to the 2021 Public Health WINS data. And so we're also able to do some comparisons of our workforce against national and kind of Region 5 data, which is the region we're in. So in Indiana at the time of this, so we did collect data in the fall of 2022. And so at that time we had captured in this data around 2,086 employees in Indiana, which equated to about little under 1,900 full-time equivalent staff across the state, or an average of about 3 FTE per 10,000 residents, which was slightly lower than the national average of 4.1 FTEs per 10,000 residents at the time. And we do show kind of a breakdown of this by population served in Indiana as well, as that was important for our folks to have that. Next slide. So some of the things we learned when we were trying to capture this data and assess it primarily were some of the issues with a lack of standardization across health departments did make it hard to kind of drill down and completely assess some of these issues, as well as being able to compare to some of the other data we had. Some specific things that we noted were issues or where there was more variability were particular around full or part-time status and how that was defined, permanent or temporary positions, including paid employees, paid interns, specifically county hired 1099 contractors were particularly hard. That definition of a contractor varied quite a bit. And so we did have to do some kind of level setting with folks and check in with them to try our best to get that figured out as well. Next slide. So in thinking about that full-time effort and part-time effort, one of the things that we started realizing as we were assessing the data was that the definition for full-time did differ, ranging from some including folks that were at 32 hours to 40 hours per week as considered full-time. So we did have to adjust our analyses so that we could create standardized kind of assessments on that FTE equivalent in there. And then another thing that did exacerbate this and exacerbate our ability to compare were lack of standardized job titles and roles within the health departments. And so a couple members of our teams, in order to do this, did essentially take all of the roles that were provided and compare and kind of iteratively go back and track and try and align them with job roles that are represented in public health WINS to allow us to, as much as possible, standardize that. Any that we couldn't, we would go and try and bring in additional reviewers to look at that and help us create that. So next slide. As far as looking at workforce education, this was another one that we thought was important and of interest to this. So we did, again, compare this to Region 5. We did find that Indiana's public health workforce has less formal public health education and training and advanced degrees than public health workers in our neighboring states in Region 5. And only about 6.5% of Indiana local health department employees had a formal public health training compared to about 11.8% in Region 5 and 12.7% of all employees in the US. And then just over 12% of our local health department workforce had a master's degree compared to 27.5% of local health department employees in Region 5 and 27.8% in nationally. So we were definitely lower on that and an area of consideration. Next. Other things we looked at were salary. Originally, we had just done this as comparisons to Region 5, and we did find that our employees did generally make less than employees for equivalent positions than others in Region 5 and nationally as well. So this is just one example. Our public health nurses in full-time positions on average made less than their counterparts. So about 46.8% of nurses earned between $25,000 and $55,000 in Indiana, compared to 77% in Region 5. So that was important, although on the next slide, one of the things that, if you can go ahead and go to the next slide, one of the things when we did present this data, so before we fully kind of released our report, we did get feedback from both IDOH as well as some of the local health department administrators. And overarchingly, they actually preferred to have comparisons by different measures, in particular by education, years worked, and then next slide. And then also they wanted to look at comparable health departments. So what did the other health departments in the state that were similar and served the similar population size, what did they look like? And so we did break it down in all of those ways. So Region 5, as well as education, time in the workforce, and looking at, can you look at the comparable health departments for you? And that was, really great to have that feedback and make sure what we were capturing and presenting was relevant and useful to those that were going to use this. Next slide. As I mentioned, we also did do an assessment of foundational public health services capacity to look at kind of where were there gaps and what were needs with this. And we did use the Public Health Services Workforce Calculator to do this and aggregated this to the state level. So next page or next slide. And so both for foundational public health service areas capacity, we found that Indiana needed additional capacity in 4 out of 5 of these areas. So with the exception of communicable disease control, all others needed, had significant gaps in capacity for that. Next. And similar, we did also find gaps and need for additional capacity in 6 of the 8 capabilities, including assessment and surveillance, organizational competencies, emergency preparedness, response, policy development and support, community partnership development, and equity. Next slide. I'm sorry, I know I'm going through this fast. So one of the things, and probably not a surprise to most of you, with the foundational public health services, one of the major lessons we learned in this was that many employees in the health departments did not feel that their job tasks aligned well with these and had a hard time providing estimation for this. So we think this may have contributed to some overestimation of effort, and really do think that there needs to be some consideration of how to better align or integrate these within current practices. So next. Other things, we did look at retention, noted that public health nurses and environmental health workers had the highest turnover and were the hardest to fill. Things that led turnover, or reasons they thought were relating to turnover, top 3 were pay, workload, burnout, and retirement. Again, don't think those are surprises or maybe necessarily different from others, but things that we did look at. Next slide. And then as far as training priorities, I think some of these aligned with where foundational capabilities and areas were lacking, but community engagement was one of the top ones, effective communication, budgeting, and financial management. We did note, we asked them about if they had any training funds, and we did hear that almost 80% had some level of budget for training and education, but often it was low and was based on a first come, first served basis. So potentially some additional capacity to support training for that as well. Next. And then as a result of all of this work, we did want to be able to recognize the effort and time that was put into this, as well as provide our local health departments with resources that they could use and informing kind of both their activities related to advocating for additional funding, and then hopefully when funding was available to use it for advocating with their local community commissioners or council members to ask for the funds that they need. So we did create individualized local health department workforce reports for each of the local health departments that did provide data. And it gave their numbers and compared them to other health departments that were like theirs, so that they could use that in supporting their conversations related to kind of needs in their areas. Next slide. So just to wrap up, and I'll quickly touch on kind of where we're at and what we're going. This was the first time that decision makers in Indiana had this level of reliable data on the number of government public health employees in our local health departments. And it did allow us the opportunity to compare kind of the strengths and weaknesses across communities in the state. Kind of our goal of this was to use this data to be able to track changes in Indiana's workforce over time, support those requests for resources in LHDs and their employees, and ultimately strengthen the public health system. And I think, as I mentioned, and as you all know, a lot of this was, part of a broader campaign to increase funding, which we did get in 2023. It was passed in 2023, starting in our fiscal year 2024. And we have seen a lot of really great things coming out of that. Dr. Yeager and our colleague Aparna Soni are starting an evaluation of this, including an economic impact of this funding in our state too. And we hope to use some of this data to look at where we're at moving forward. But we're also in another budget year this year, and so we're anxiously seeing what's going to happen with our funding, and hope that we can see sustained funding, or at least continued funding in this area. So next slide. I think with that, I am done. Just wanted to highlight, as was mentioned before, I do have a link to the report. This also has a link to a webinar that had this data, but much more in it, and then a link to our paper on this in the Journal of Public Health Management and Practice. So.
Well, thank you, Katie. Thank you, Andy. Thank you, Stephen. Thanks to the commission for inviting me to invite these folks to come and talk with you. And I want to just defer back to the chairs to determine whether and how to have Q&A, since I'm not physically in the room with you.
Okay, great. Thank you, Kathy, and thank you to all our presenters. Questions, observations, comments from anyone in the room here? How about online?
Hi, thank you so much, and really great presentations. Appreciate all the information that was shared. And Katie, good to see you again. Appreciate you connecting again with us and sharing the Indiana story. I think my questions are more on the line of workforce. So how did this information, like what kind of recommendations actually came out of this other than funding? Recommendations related to the workforce that we could look at as well when we're here in Maryland.
So a lot of it was around kind of those capacity areas and where there were gaps in it. Our intention was specifically to create resources for the local health departments to advocate for those. As I mentioned, we are now moving into full evaluation. So I think I would probably defer you back to Dr. Yeager as she begins to do that work with our colleague on kind of what the impacts were. We essentially, did this, handed it over. We do know that a lot of local health departments used it to advocate for their funding, and also for informing kind of where, as they got that funding, they could shore it up. The health department, state health department, did work within their internal groups in developing the KPIs, and which informs what the health departments kind of are required to do as a part of this funding. So I think other things that are coming out of this is that the IDOH also created regional support groups to help health departments as they're implementing this. And some of that is supported through the public health infrastructure grant funds. But some of that work did inform it, things like
that, kind of looked at funding, but I think those were mostly just appropriation bills, budgets. But as far as changing the structure itself or the formula. I think that's not something that we've seen, but then again, we haven't really been looking for it. I'll find this blog post that she did where she gets into some of the recent legislation that she found just in the past year. But unfortunately, we don't have anything that can really show the trends over the last few years as far as like changing formulas or adding conditions and requirements and so forth. That's a great question.
Thanks.
Great, Matt.
Andy, thank you for your presentation. I know the great work that ASTAR does, particularly in the DEI space and other areas. My question is, have you seen in your discovery any of the states that use multiple of those models? The set amount, the negotiation between the local, the grant funding as like multiple different avenues, reimbursement, because we seem to have a very complicated system here. And I'm wondering if that's something you've seen in your assessments.
Yeah, I think I'm looking here at the list that we have, and I think the summary for in Minnesota, there's kind of a match plus a minimum standards requirement, but also they use a formula to determine it. So I think the states are they've mixed and matched the mechanisms, conditions, and funding determinations. I think they just kind of have, and again, I wish we could tell you this combination is like brings about the best health results and so forth, and that's just something that we don't have the research on. But it does look like from the data that we've collected that one state might use a formula, but they also require a minimum contribution, whereas another state that uses a formula requires an application of some sort. So it really varies, and they're pretty mixed and matched.
I think I would be really curious to hear what if you come back to this is the actual best model for state health departments and local. That would really be pretty amazing.
On a related note, is there any? Have you heard of this ARPA-H? And is it working? I mean, my understanding is they're kind of buying outcomes or trying to buy outcomes. Maybe that question is for Andy, I think.
What I didn't catch what it is.
I don't know where the microphone is. ARPA. The question is about ARPA-H. I think that's what it's called. ARPA-H.
Right. It's like DARPA, but for health.
Right.
It's connected to NIH.
Oh.
Research.
Yeah.
For outcomes. Right.
No, I'm not familiar with that.
That's not be very big.
Okay.
No, it's in its second year of existence now. So ARPA-H is out there, trying to sort of get into the world of innovation, if you will, right? Innovative approaches. So.
Oh.
Okay.
Any other questions for our panel here?
Just one for Stephen. Actually, the CIE I thought was a really intriguing concept, and appreciate how you went through some of the mechanics needed to set something up like that. Obviously, here in Maryland, we have CRISP, our Health Information Exchange, which is pretty powerful and has been a wonderful resource for us within kind of the healthcare space. I know there have been attempts to bring in, health associated data sets and so forth, but we really haven't, to my knowledge, folded in some of that social service data, some of the data from schools and so forth. So just curious if the experience in Chicago, if it involved the education sector, and if so, how you addressed FERPA, and if it included law enforcement data as well, in a way that wouldn't bias care received, but in a way that would help inform things like substance use treatment and so forth.
Yeah, thanks very much for that question. And actually, to my knowledge, in Chicago, they have not incorporated these other types of data that you suggested, like school data or police data. And I do recognize too that, benefits and some dangers to different approaches. Certainly, I have seen, incorporation of different data sets with a view to improving public health beyond the CIE context. Certainly have seen some research projects and try to, well, not try to, but we, work through some data sharing barriers in that regard, looking at combining different data sets. I'm not at the Chicago Department of Public Health anymore, but it's a great health department, and they have done some amazing work around predictive analytics and modeling and incorporating different data sets that, really raised kind of questions around how do we share different data sets that all have different legal rules around them and different requirements. And often, many of these rules around privacy they're just not consistent with the work that is done in public health in 2025. So there's often challenges, but maybe that's a CIE 2.0 vision. But I appreciate the question.
Great. I'd like to thank our panel for their discussion and the expansion of our knowledge base here. Kathy, thank you for getting everybody together, and we do appreciate you being part of us. Let's now move to the last portion of our agenda here today, and I know we sort of had an addenda to some of our discussion, and that was in particular something both Fran and Chris brought up. Fran and Chris, are you ready for any movement?
Sure. So this is tagging off our previous discussion about the development of a population health trust in Maryland. It is written into the state's agreement with CMS for the AHEAD model, the existence of that trust, and the action that the HSCRC took to approve, to get approval of the staff's proposal, yielded a resolution of funding for 1 year to the Population Health Trust. And I'm blanking on anybody want to target or guess about how much, I'm blanking on the dollars. How much was it?
25 million.
25 million that, without getting into the complications of the hospital rate setting, is available with only this 1 year commitment and no commitments to the out years. So it is now up to the legislature to take that proposal and to craft an entity that will do the work of identifying what the mission, what the charge of that entity is, and importantly, I think from everyone's perspective here, what the purpose is, and also what the governance, what the structure of that entity will be. The idea is not that it's just 25 million, and hopefully that would continue in out years, but that it would be a locus for public and private investment. So I think, as Chris mentioned, there's a lot of insurance carriers, not the least Medicare, Medicaid, but also commercial insurance carriers who benefit from the work of public health, and who would like to see communities be more healthy. And so the idea of this trust would be to spur that kind of private sector investment along with continuing public investment. And then to make those kinds of investments based on data, based on expertise, and based on assurance of outcomes. So that's all very vague. We think that there's some elements to that structure. I shouldn't say we. I think there's some elements to that structure that have to do with the values, sort of like we talked about, as far as being nimble, about being able to be have confidence, to be trustworthy as an entity. Otherwise, that trust would not garner the confidence and support of private investors. So all this is to say that I think what Chris and I would like to propose is that we sketch out in less than 1 page an outline of an ideal purpose and structure to suggest to the legislature as they review these bills, which have not yet been introduced, that would define what the population health trust is for Maryland. So, Chris, if you want to help out on any other points to make.
Yeah, a couple things. I think and the question is whether we can all get around this or not, but I think one is like, we want the population health trust. We've said that, we like it. We wanted to focus and support innovative approaches to activities that measurably improve outcomes for communities in Maryland, I think is one, particularly activities adjacent to the care delivery system. This is important to say because they're paying for it also, like sort of, at least they think they're paying for it, the health systems. So I think we want to say that. I think we want to say we support an organizational structure that's independent from government, but with the distributed governance system that includes experts representing state and local public health, that includes health systems representation and also private philanthropy. I mean, so I mean, this is like, and then I would just emphasize that the trust remain nimble and independent of the bureaucratic stakeholders, notwithstanding the involvement of the government. So that would be, those were like, that was a real quick.
Right. So this is right off the top of our.
Right, so off the top of your heads, what I would advise, just so we keep up with sort of this being commission business, is for the two of you to craft together that one pager. One that we can potentially get through on a mail vote. Is that doable? Or do we have to have a commission vote on this? This is sort of.
I don't. That's with Open Meetings Act.
With Open Meetings Act.
What about, can we move with the premise of this, that the exec session that we delegate the authority to the execs to approve? Does that make sense?
As a motion that we, the commissioners.
Yeah.
Okay.
That basic.
So state your motion right now then.
Ooh, all right.
In a succinct fashion, and somebody get this down as we can go through the recording. So give me a motion basically to empower the execs to
empower the execs to issue a brief letter of support of the Population Health Trust and
to include
goals around measurably improving public health outcomes for communities in Maryland, and a governance structure that is independent, a governance and organization structure that is independent from government. So it's a separate entity, hopefully maybe a nonprofit or some other. Separate from government, and with a distributed governance structure to include experts representing state and local public health, healthcare delivery system experts, health systems, and leading philanthropies.
Right.
And I would do social.
That's sounding like the content of the letter. Could it be more like abbreviated that we can have, a very succinct motion? Well,
the motion basically directs the exec committee to pen the letter that includes these components, right?
Right,
And
right. Yeah.
And I realize
The
we're being
goals,
rushed
yeah.
to this, but the reason we're being rushed to this to some extent is the timeliness regarding the legislative session and the uncertainty when this all is going to be moving ahead.
Correct. Like if we were going to influence the bill, it's better to
Okay.
do it before the bill.
So with that stipulation that this empowers the executive, what do we call ourselves? Executive or the co-chairs? The three co-chairs to come up with a letter based upon this, the factors thrown in. Do we have a second to that motion? Yeah, we have a second in Fran. Do we have discussion? In particular, discussion, is there comfort or discomfort on our virtual audience? Because we're looking at each other here, and I think in general, nobody's having angst over this. Is anybody having issues online from commissioners?
Just no angst. I'm just for clarification though. I think we're talking about funding being compiled in this trust in a non-governmental or quasi-governmental, perhaps, I'm not sure what the sentiment is there, that is informed by a board of some sort that includes governmental representation as well as the others?
Yeah, so CRISP is an example.
Right, that's what I was thinking.
CRISP being a nonprofit, but one that obviously serves public health objectives, but that does have a nonprofit corporate board of directors, which is a diverse group. So I think that is a good example of a parallel entity.
Thank you.
Other discussion?
I mean, I would add that it should have representation from the social service sector as well, because we're focusing a lot on the social terms of health, and also probably the just the general, someone from the general public that's knowledgeable of maybe a constituent or something.
Yeah, I was thinking that a patient representative as well as someone from the general public.
Please not. Rosalie, this is only for commissioners. I'm sorry.
Sorry, I thought you were calling on the public. Sorry.
No, the public was mentioned in that. Any other commissioners with comments on this? We have a motion with amendments as presented. So are we ready to pass the vote on this? Okay, all for empowering the chairs to set up a letter of support with the stipulations as stated, please say aye.
Aye.
And we're looking for hands or other things. So ayes on there. Thank you. And any nays on board? Please monitor on the website, on the screen. Do we have nays from the commissioners? Any abstentions? So the motion passes and we will move on that.
Nice.
Thank you. And well, again, I think this is part of the idea is we are in a timely situation, and for us to have to sort of punt on this for another month, we may lose precious time on this. Thank you very much for bringing that to our attention. And I want us to be a robust body. We shouldn't be stuck into sort of bureaucracies. And I realized I didn't follow completely the Robert Rule of Order. There should have been a vote on the first one and then amendments and all that, but we'll get it done. Thank you all. Any other discussion, any other items before we close? From my perspective, here are the announcements. Our next monthly meeting is Thursday, February 20th from 2 to 5. It'll be in this location here. We also have noted that the 2025 meeting dates have been set and calendars will be updated. The dates will be February 20th. March 13th, April 3rd, plus an additional meeting that's already been sent out, correct? I think it's the 15th.
That's correct.
May 1st, plus another additional meeting, virtual, which is what?
May 20th.
May 20th. Then June 5th, July 10th, August 21st, and September 11th. So again, that should be available. And if you don't have all the information, please send us an email, Shane an email. We'll make sure to get that on your calendars, please. I'm now looking for someone to set up or propose a motion to adjourn our meeting today.
So moved.
With enthusiasm. Tosin was like, please choose me.
Oh.
Matt, with also enthusiasm, seconds it. All commissioners can vote who wants to adjourn today's meeting. Does anybody not want to adjourn today's meeting? Does anybody abstain? Thank you all. We once again have provided us our goal, which is learning and then moving ahead. So thank you all for your attendance today. I call this meeting to dismissal.